Okay. So today we're gonna, first thing we're gonna do is review the flow of blood through the heart. And then we're going to watch a little video that talks about what happens when a coronary artery gets blocked. And so here you can see, this is the diagram that I've given you. And so with this, what circuit? So we have two circuits. So what is this circuit called? Does anybody remember? This goes out to the body. So what's this circuit, is that one called? What does body wide mean? Anybody remember? Systemic. So you can write systemic circuit next to that one. Actually, I'll turn on the lights here. So that would be the systemic circuit. And so this one would be what? It's going to the lungs, so it's called the what? Pulmonary circuit, okay? Okay, so you don't have yours colored in, but this would be the oxygenated blood, so you could write oxygenated down here, and then up there would be deoxygenated blood. So it'd be red and blue. So blood first comes in to what chamber after it leaves the capillaries found in the body? It's an atria because that receives blood from the body, but is it the right one or is it the left one? It is the right. And so you're looking on this page, remember, and it's like, well, how could that be the right one? But remember that that is due to the fact that it is anatomical position. So it's the person's right atrium. It's not the way that we are looking at it. So I would label this one right here, the right atrium. Now, it's really important to realize that we're going to talk about the cardiac cycle. And actually, I'll just mention it here. So we're going to write on here, the cardiac cycle. And this describes the contraction and relaxation of the different chambers in the heart. So contraction and relaxation of the chambers in the heart. Okay, so we have a name for the contraction and it's called systole. So systole means contraction. And so what do you think the relaxation is going to be called? Not asystole because that's without contraction. I guess you could say it would be asystole, but it's actually called diastole. So this would be relaxation. Okay. So where have you seen systolic and diastolic before? Blood pressure, right? And that actually has to do with ventricular systole. So ventricular systole is the higher number when we talk about blood pressure, and ventricular diastole is the lower number. But also the atria have to contract and relax as well. So when we look at this one, this is not what's labeled on in the diagram in the book, but I want to mention it here. So if the atrium is filling up, that means it must be relaxed, right? And so we would say that this is a atrial diastole. Okay, so it's relaxed because it's going to receive the blood. So when it forces the blood down into the right ventricle, it does so by contracting. And so this would be here, this would be atrial systole. So you can notice that the atria looks kind of like deformed, and that's because it is contracting. And it is pushing the blood into the right ventricle. So this one, this ventricle would be ventricular diastole. Right? Because the ventricle has to be relaxed if it is going to receive the blood from the atria. And so then you'll notice here that the ventricle contracts. And so this one would be under ventricular systole. and the blood comes out, and this is what we refer to as a pulmonary, and it's leaving the heart. So would it be an artery or a vein? Artery. So that is the pulmonary artery, right? So by definition, we actually haven't talked about blood vessels specifically in our notes, but I mentioned before, but by definition, a blood vessel that is carrying blood away from the heart is technically an artery. A vessel that contains it back to the heart is a vein. And so that would be an artery that is carrying unoxygenated blood. So when it comes back, okay, what would these vessels right here be? Are those the pulmonary? Yes, so these are the pulmonary veins. Okay, so this one right here would be the left atria. So then it goes into the left ventricle, right? The blood flows, and we could talk about atrial, left atrial systole and diastole again here. I'm not going to write it down. But here you notice it goes into the left ventricle. Then the left ventricle contracts the same time that the right ventricle contracts, and then it forces blood up and out. And this is actually what is referred to as the aortic arch. And then it branches in to the blood vessels that we'll talk about probably next week. So that's the aortic arch. Okay. Are there any questions? Yeah.
Which one was the pulmonary vein?
So these are the pulmonary veins right here. And actually there's one here too, but it's coming from behind, so it's coming from the other one. And so it actually, you can't see it, but it would actually come here. Okay. So these would also be technically pulmonary veins. Okay. But notice how they're not entering the right atrium, they're entering the left atrium. Okay. Yeah. So how do you say atrium or atrium? Oh yeah, you know what? I said this wrong. Because atria would be plural, atrium would be singular. Okay. So left atrium, left atria. I'm saying it in the plural, like in general, left atria is plural. But yeah, so I would not do it. I think atrium is singular, atria is plural. Yeah. So it's not atriums. Yeah, good question. Okay, any question about that? Okay. So we're going to watch a little video. And specifically, this video talks about what we were mentioning at the last lecture when we were talking about what happens when blood vessels to the heart can get clogged. And so let me just get this to work. Do we have volume?
Our lives depend on the health of our coronary arteries. Yet 16 million Americans suffer from coronary artery disease. Georgia Chan Downard is about to discover that she is one of them. She never suspected that, like so many others, she was at risk. But her doctor did.
My doctor thought it was about time I had a stress test. I could tell as he was looking at the graph that there might be something. Maybe it was instinctive on my part. Maybe I was just nervous. And he turned to me and he said, there are some irregularities here. I didn't really understand until I said to him, well, exactly what does this mean? And he said, I think maybe you have a blocked artery.
Heart disease was far from Georgia's mind. She had no obvious symptoms, no chest pain, no shortness of breath. But Georgia did have high cholesterol and a family history of heart disease, which worried her doctor. He recommended a closer look. a non-routine procedure using a highly sophisticated CAT scan that can picture the beating heart in 3 dimensions.
This is what your heart looks like in your chest. It's not like an artist's rendition. It's really actually what it looks like. Here is the left coronary artery that comes off of here. This artery looks very large and healthy up here, but then suddenly there's a big change from this size artery down to this size artery, and then it kind of opens up again. This right here is the area where it looks like significant blockage.
Because her artery was severely blocked and appeared vulnerable to imminent heart attack, her doctors decided to insert a stent, a tiny mesh tube to open the narrowed artery. Stenting is a routine procedure, but very recent studies suggest that some patients may do as well with intensive treatment with drugs. Georgia's hidden heart problem is due to atherosclerosis, deposits of plaque in the artery wall. In healthy coronary arteries, the blood flows without obstruction. In diseased coronary arteries, a fatty substance called plaque forms in the artery walls, and as the disease advances, may bulge out into the path of the onrushing blood, blocking the oxygen and nutrients the heart desperately needs, and from time to time, causing symptoms like chest pains and shortness of breath. But heart attacks result more often from plaque that does not protrude into the artery itself, but remains hidden in the artery wall.
One of the scariest things about coronary artery disease is that it can remain silent for so long. You can have plaque buildup in the coronary that isn't causing you any problem, doesn't cause you any symptoms, doesn't even cause a positive stress test, but suddenly ruptures. It ruptures, it causes a blood clot to form, the rest of the coronary artery, the rest of the pipe suddenly gets blocked, and a heart attack occurs. And that's really the most common cause of heart attack. This is what kills people, often in the prime of their lives.
All plaque is dangerous, but some plaques are unstable, on the verge of rupture. Scientists are today trying to determine how to identify the unstable plaque, while doctors try and help patients minimize their risks.
The plan right now is to manage the coronary disease in your arteries. Your blockage, if it was up further, up at the very origin of that artery, that's a very dangerous obstruction. And if it closes, generally causes a very extensive amount of damage to the heart. Your blockage was in the mid portion, it would still cause a pretty good amount of damage. That would certainly alter your life, but it's not exactly as lethal as the more proximal regions.
I have a small gym in my building. Do you suggest I, go down and exercise?
I would not. I would wait.
No?
I would do
Wait
all of your
until
normal
after
activities. I just wouldn't be breaking a sweat. I wouldn't be getting on a treadmill at this point, only because there's some evidence that you can jeopardize the stent opening.
Okay.
So if you do it too early.
Okay.
So what we're going to do next is.
What a pity. Sorry.
Well,
I'm not a big fan of exercise.
You'll get there.
I know.
And by the time you finish cardiac rehab, you'll love exercise so much you won't be able to wait.
Okay. Any dietary restrictions other than the obvious?
The obvious. It's really fat, cholesterol, red meats, egg yolks, cheeses, whole milk, switch to skim, more fish.
60 years ago, doctors rarely prescribed diet.
Okay. So that very last part, they've actually rescinded that idea that dietary cholesterol does not now seem to play a big role in the levels of cholesterol in your circulatory vessels. And so now they say that you can actually eat egg yolks now because that does not affect the cholesterol levels in your blood. Okay. So we were talking about the coronary circulation. Oops. Oops, wrong way, sorry. Topic. Okay, so we were talking about the coronary circulation, and so these, remember, are the coronary arteries, And so a blockage can be due to plaque buildup in this. And this has a name, and it's called atherosclerosis. So atherosclerosis is the buildup of plaque in arteries. And it can lead to a heart attack if it occurs in coronary arteries. So much more important than the amount of cholesterol. Remember, I mentioned before, cholesterol is not soluble in water, so it has to be transported via lipoproteins. So when we look at these lipoproteins, and we look at the transport of cholesterol in the blood, it can either go from the liver where it's stored, so cholesterol can be stored in the liver, or it can go out to the tissues, and there's these two directions that it can go. And so when we look at the, liver, two directions to tissues. Okay, so this is the transport of cholesterol, right? And so, for example, when it goes out to the tissues, this is the LDL, which stands for low density lipoproteins. HDL carries it the other way. So from the tissues, it gets stored in the liver, and this is actually good. So we want HDL is what is referred to as good cholesterol, because it stores the cholesterol in the liver where it doesn't form a problem in the development of plaques in the circulatory vessels. And so LDL is what is referred to as bad cholesterol. Right. So when they say that you have high levels of LDL or bad cholesterol, that's when we start to worry about heart disease. So I have this that like runs in my family. And so I have high cholesterol, but it's actually high LDL levels in my blood, right? So my mother, for example, had heart disease. She had heart failure, and and also high blood pressure. So she was at a great risk, right, for a heart attack. So you understand that it's really not the cholesterol, but it's how it is transported in the body. And so when they talk about cholesterol levels, they're actually referring to the lipoproteins that transport them. Okay. Any questions about that? Has anybody ever had their cholesterol levels checked, the LDL and HDL levels? No? Okay. You guys are too young, I guess. Okay. So we're going to talk also today about the histology of cardiac muscle. And so I'm not going to get into great depths about how the contraction develops and what that depolarization is, because next quarter we're going to talk extensively about skeletal muscle. And then I'll talk, after we talk about skeletal muscle, we'll compare it with cardiac muscle. So one of the interesting things about this cardiac muscle cells is that they are branched, and they have what are called intercalated discs between them. Okay, so intercalated discs. This actually allows for the muscles to contract against one another. So it actually kind of forms an internal skeleton of the heart. Because if you think about it, cardiac muscle has to just contract against itself because it's not contracting against bone like skeletal muscle. And so these intercalated discs consist of desmosomes, which we talked about previously, which are proteins that connect cells. And this creates, so if one cell contracts, it will kind of keep the cells together, right? So those are the desmosomes. And then we also have what are called gap junctions. And so these are ion channels. So these keep cells connected. So what that means is that ions can pass from one cardiac muscle cell directly to another through the gap junctions. The other interesting thing about these cells is that they have very large and numerous mitochondria. So large mitochondria, and I'll put very numerous. So there's lots of them. And this is due to the fact that the heart runs on aerobic respiration. So this is cellular respiration that requires oxygen. Cellular respiration that requires oxygen. And the good thing about this is because it uses aerobic respiration, it doesn't ever produce lactic acid. So this means that it is fatigue resistant. Right? So anaerobic respiration sometimes produces lactic acid, and the lactic acid is what can cause the muscle cells to fatigue and not work properly. Okay. The other important thing about kind of physiologically the cardiac muscle cells is that they cannot sustain contraction, so they do not go into tetanus. So they cannot sustain continual contraction like skeletal muscle can. And so they don't go into tetanus. So I'll just put no tetanus. And this is not the tetanus like you get a shot for. This is when the skeletal muscle contracts, sometimes it stays contracted for long periods of time. And the heart cannot do that. So it doesn't contract and then just stay contracted. And so it has no tetanus. Okay, so I gave you a little sheet. So your second sheet of paper is this diagram right here. Okay. The other thing that is important to note is that this is striated. So you can see the striations. So I'll put striations. So it is striated. Also, it generally has two nuclei that are kind of in the center of the cell. So I'll put this is my nucleus, and this is my other nucleus inside the cell. So what this suggests is that during embryonic development, cells will fuse, right, to form, so two cells fused, maybe to form one cardiac muscle cell. Okay. So this is the intercalated disc. So here you can see it in the picture. So this is my intercalated disc. And it is made up of these, which are called the desmosomes, and these, which are called the gap junctions. And so what do you think these little round objects here would be? We mentioned it before, there are organelles inside the cytoplasm. These are the mitochondria. Okay. We'll talk about what these striations are next quarter, but if you've studied muscle physiology at all, it has to do with the overlapping actin and myosin proteins that when they slide together cause the whole muscle cell to shorten. Okay, but we'll talk about that later. Now there's one other thing that I want to mention here. This is a very special structure that is only found in muscle cells, and this is called the sarcoplasmic reticulum. So if you remember from your cell biology, we had endoplasmic reticulums, smooth and rough, But this is a, sorry, not reticulum. This is just reticula. Sorry, reticulum. No, it would be ulum. Sorry, it'd be ulum. Okay. So this is just a special type of endoplasmic reticulum, and it's called sarco. What does sarco mean? Sarcophagus. Dead flesh, right? So it'd be like a sarcophagus would be flesh, right? And phagus actually means to eat. So, so the flesh eating. So sarco means flesh, so that's why it's called the sarcoplasmic reticulum. And this stores a really important ion that is necessary for all muscle contraction, but it's really important for the heart, and it is calcium ions. So this stores calcium ions that are needed for muscle contraction. And we talked about parathyroid hormone, which regulates the blood levels of calcium, and how important it is to maintain that. And one of the reasons is that you need your heart muscle to have a sufficient supply of calcium. Extra calcium can sometimes cause the heart to contract irregularly, though. So you don't want too much calcium, but just enough calcium in your blood. Okay, so that's the histology of the cardiac muscle. So now we're going to talk about the heart physiology. So one of the really interesting things about heart muscle is that it can contract, heart muscle cells, cardiac muscle cells, can contract without a nervous stimuli. So cardiac muscle cells contract without nervous stimuli. And it's actually quite amazing. They can take individual heart cells and put them in petri dishes, and an individual cell will just sit there in the petri dish if it's got nutrients in it, oxygen, right? And it'll just like contract by itself. And then you can put another cell in there and it'll contract, and it could be contracting asynchronously, but once you put them together and they touch, then they create a connection and they'll contract together. So they tend to contract together. But this was without stimulation from the central nervous system. There is a little nervous stimuli in the heart itself. And so we call this intrinsic regulation. And it has to do with what is called nodal tissue. And nodal tissue can produce its own stimulus for contraction. So this can initiate a contraction. Okay. So this is our pacemaker of the heart. And so our pacemaker is a special type of nodal tissue that is referred to as the sinoatrial node. This is abbreviated as the SA node. Now I kind of remember where it's located because it's actually located up in the right atrium. So just remember atrial, kind of, I don't know what sino means, but atrial would mean it's up in the right atrium. So we'll just put located in upper right atrium. Okay, so this is what initiates it, and it initiates it at about 75 beats per minute. So it would kind of create the average normal resting heart rate, but obviously the heart can increase in when it needs to, and it can also decrease. So athletes, for example, might have a resting heart rate that's below that. Okay. We also have what is called the atrioventricular node. So this is abbreviated as the AV node. And this is kind of located in the bottom part of the right atrium, near the connection between the atria and the ventricle, okay? So it would be between the atria and the ventricle, the right atrium and the right ventricle. And it has a special function in that it delays contraction by just a microsecond. So by like 0.1 seconds. And the reason why it does this is that you want the atria to contract, and then you want there to be a little bit of time before the ventricles contract. So you want the atria to be able to relax before the ventricles contract. So we need a little delay in that. And then it goes to the atrioventricular bundle. So we have the atrioventricular bundle. And then this branches to, I'll just write AV, branches. That's an abbreviation for atrioventricular. And then it goes into these little fibers that innervate the bottom of the ventricles, which are called Purkinje fibers. They actually have another name in this edition of the book, but Purkinje is what I learned. So this is in the ventricles. And so it's really important to realize that the signal has to go to the bottom of the ventricles so that the ventricles will contract from the bottom up. We don't want the ventricles contracting from the top down because it'll force blood to the bottom of the heart, which can actually damage the heart walls. And so this part right here, this part right there, right, allows for the ventricles to contract from the bottom up. So that's the function. So this just carries the signal to the bottom of the ventricles. So you have a quiz on Wednesday, and so you need to be able to identify the different components of the intrinsic part of the heart, right? So this is my SA node, sinoatrial node. Notice how it sends a signal to both sides of the atria. So that causes the atria to contract. So that would be atria systole, right? So the atria contract, and then they force blood down here, and then we want it to pause. So that's the AV node, and then it takes it to the AV bundle. These are the AV branches, and then these are called the Purkinje fibers. They actually have, they're calling them the subendocardial conducting network, right? But we'll just call them Purkinje fibers, okay? So the Purkinje fibers are what delve into the muscle and cause the muscle to contract. Okay. So this whole conduction of this electrical signal through the heart can be measured using an electrocardiogram, right? So we can talk about the electrocardiogram. This is also abbreviated as ECG. Okay. Does anybody know why they sometimes call it EKG? Instead of ECG. It's because in German, cardio is with a K. Okay, so ECGs and EKGs are the same thing. It's just the German version of it is EKG. Okay, so here you see what we're measuring here is actually the movement of the electricity on the surface of the heart. And so when we look at an EKG, and I'm going to draw it, but here's a picture of it so we can kind of draw it. So the first thing that happens is you get the depolarization of the atria. So the atria contract, and this is what is referred to as the P wave, right? So I'll put this is where the atria contract, or they depolarize, but we'll say they just contract. Okay. So that's the P wave. And then we get a little dip here, which is Q, and then we have R, and then we have S. Okay. So I'll just write, this is Q, this is R, and this is S. Okay. So we have what is called the QRS complex. Can't make it any taller, sorry. Okay, so that's the QRS complex. And that is where the ventricle contracts. Can you see something? Can't see something?
No, it's the so is the QRS complex a part of the P wave?
No.
Or is it like the R wave?
This is the P wave.
Okay.
This is the QRS complex. Okay.
Understood.
So that, yeah, so this would be the, you'd point to this. This is the P wave. Okay. Does that make sense? Okay. So then we have another wave, right? And right here, this would be the atria relaxing, right? When the ventricles contract, the atria relax, but it's kind of hidden, right? So we don't see that difference in the depolarization, but we see ventricular relaxation, which is right here. And so this is what is called the T wave. And this is where the ventricles relax.
Is there any like noticeable comparison between the Q wave and the T wave? Like, is one usually bigger than the other, or is it just about the same?
Looks like the T wave's a little bit bigger in this one. The P wave should always be closer to the QRS than the T, I believe. And then because we have what is called, but we don't want it too long, because hopefully I'll find my video that I wanted to show today, but there's what is called the long QT syndrome. And long QT syndrome has to do with the fact that there's too much time between T and Q, and then that can sometimes cause people's hearts to just stop, right? And so then they actually have to shock them back awake. Question?
Pioneer Hall.
Yeah.
Oh man, you guys are getting notices?
Yeah, it's got a cold. It's got a cold.
Are we supposed to evacuate?
No, I think we're good.
We're supposed- Mr. Streeter was supposed to stay in front.
Oh, shit. What? We'll see. I didn't get a notice on my computer. Okay, maybe there'll be an alarm. Okay. Okay, so that's QRS. So sometimes you can get the atria not contracting properly. And so this is what is called atrial fibrillation, right? So let me see if I get a new topic, whiteboard. So we have atrial fibrillation. Okay. So generally what atrial fibrillation will look like is that you'll have an abnormal P wave. So it could look something like this, and then you have QRS, and then T, and then you'd have something like that, QRS. And so this is a really common thing that people have. And so this is called AFib. Right? So they say, oh, I mean, older people always talk about their AFib, right? And sometimes is referred to as like palpitations. Like when your grandma talks about her palpitations, this is what happens. And atrial fibrillation can actually be due to extranodal tissue. So it can be due to extranodal tissue. And it is actually really common in athletes that exercise like for long periods of time, so aerobically. So like long distance runners and also like bicyclists can sometimes get AFib, and it has to do with their heart kind of expands to pump more blood, and then they can get this extranodal tissue happening. And so does anybody know what sometimes they do for this? What can they do for this? Does anybody know, have anybody known anybody who had AFib? Yes, and so there is a procedure called ablation. So this is where they go in and they burn or freeze off the extranodal tissue. So generally they go in through a vein, so they can actually go in through the vein in the groin area and up into the right atrium, and then they can find where the extra electrical activity is in the heart, and they can freeze it off. And they can, then what happens is that the heart rhythm goes back to normal. So this is not too bad. You can live with atrial fibrillation for long periods of time, and there's lots of drugs that you can take that can help you live with it, and there's actually a cure, ablation, right? The really bad thing happens when you get ventricular fibrillation. So this is life-threatening immediately, right? Because this means that your ventricles are contracting abnormally and not pushing the blood out of the heart in a proper fashion. So we get ventricular fibrillation. And so that sometimes just looks like this, right? Like that, you know? So it's just crazy. And so one way to treat this is by shocking the heart, right? So you use a defibrillator. So we actually have some defibrillators, right? This is shocking the heart. So this shocks the heart, stops it, and then hopefully the electrical activity will resume. So they actually have automatic defibrillators right now. You can be trained to use. So, I mean, obviously you use the ones in the hallways. Yeah. Okay. So in your book, there is pictures of these as well. Yep.
So what generally causes the ventricular issues?
That's a good question. I don't know. I don't think it has to do with nodal tissue. Stress.
And that's like, you hear that common in surgeries.
Yeah.
Because I know, like, when my son had open heart surgery, he wanted to be able
Right.
and
Yeah, I'm not sure. That's a good question. Okay. So then in your book, they show different tracings, and then they talk about how what some of these tracings mean, right? So the normal sinus rhythm with the P, QRS, and T waves. And then when you look down here, right? So this would be ventricular fibrillation. Acute heart attack. Oh, electrical shock. It says right there. So if you have a heart attack, or if you're shocked, maybe, yeah. Okay. Okay, so that's intrinsic regulation of the heart. We also have extrinsic regulation of the heart. So when we look at extrinsic, this means outside of the heart. And so this would be the nervous system. Also could be hormone. So I'll put nervous system, hormones. So in our central nervous system, we have what is referred to as the medulla oblongata. This is part of the brain stem. So it is involuntary, and it is also where we have the autonomic, visceral autonomic reflex syndrome or symptom, center, reflex center. So when we look at the medulla oblongata, we have places that send signals out from the parasympathetic nervous system So parasympathetic, is that fight or flight or relaxation? Anybody remember from maybe psychology? Relaxation, right? And so we have what is called the vagus nerve. So the vagus nerve is actually a nerve that comes off of the brain and then comes down and innervates the SA node. And so this decreases heart rate. Okay. Then in the sympathetic nervous system, we have nerve fibers, just like nerves, but just spinal nerves, not cranial nerves. And these would increase heart rate. So we say that these are nerves that innervate the SA node. So I'll put innervation of SA node. So in your book, they have a picture of this. So here we see in green, we would see the sympathetic, I believe. Yeah, sympathetic. So sympathetic is in green. Notice it innervates both the SA node and the AV node, but that innervation of the SA node is what's going to change the rhythm. And then the vagus nerve comes down and also innervates it. And so this is a homeostatic balance mechanism, right? So we have a balance between stimulation by the parasympathetic and sympathetic nervous systems that can lead to the normal healthy heart rate, which remember, actually I don't think I showed you that video, that it actually varies dramatically, your resting heart rate varies dramatically over time, okay, in response to being able to respond to the environment. Okay, we also have hormones. And so if we look at one example of a hormone that affects heart rate, the gland would be the adrenal glands. And these actually sit above the kidneys. And these release norepinephrine, which is kind of the fancy name for adrenaline. So with stress, your adrenal glands can release norepinephrine, and then this is going to increase heart rate. So both the nervous system and the endocrine system are extrinsic regulators of heart rate. Talked about the cardiac cycle, so I'm going to skip over that. Okay, so the last thing I'm going to talk about today is what is referred to as cardiac output. So this is the amount of blood that is pumped out of the heart with every minute. So it's the milliliters of blood pumped out of the heart every minute. So we'll just put amount of blood pumped out of heart each minute. Okay. And it is abbreviated as CO. And CO is equal to your heart rate. So there's the time. So that would be the number of beats per minute. So beats per minute times the amount of blood that is pumped out of the heart, which is called the stroke volume. So this is called stroke volume. And this is the amount of blood pumped out of the ventricles. So obviously, when you, the sympathetic nervous system initiates and causes heart rate to increase. If you increase the heart rate, you're going to increase the cardiac output. So if you, for example, if you're exercising, you're going to have an increase in cardiac output. If you're nervous, you're going to have an increase in cardiac output, right? If you're releasing norepinephrine, your adrenal glands are pumping it out into your blood, you're going to increase cardiac output. So let's look at what determines stroke volume. So we'll look at what determines the amount of blood that is coming out of the heart with each ventricle contraction. So the first thing that determines it is what is called the preload. So this is the amount of blood that is returning to the heart from the body and the lungs. So I'll just put the amount of blood returning to the heart. Can't read that very well. Okay, so that's our preload. So if you have low blood volume for whatever reason, if you've lost blood or if you're not producing enough blood or if you're dehydrated, your preload is going to decrease, and that is going to decrease your cardiac output, okay? The other thing that affects stroke volume is the contractility of the heart. So the heart can actually contract more forcefully in certain instances to eject more blood, right? So if the heart actually contracts more forcefully, more blood is going to flow out, okay? So we'll talk more about that in a little bit. So that's the contractility of the heart. And the third thing is what is called the afterload. Okay, so the afterload is really important because this is the pressure, the blood pressure that's exerted back onto the heart. Right. So if you have high blood pressure, your afterload is going to be greater and it's going to be harder for the heart to pump blood out against that pressure. So if you have too much blood, if your blood is too viscous, like we talked about, you have too many red blood cells, you have polycythemia, then it's going to be harder, or if your vessels are contracted, you have high blood pressure, clogged vessels, then it's going to be harder to pump the blood back out. Okay, so that is what is referred to as afterload. So in your book, they have a diagram that shows all the different ways that it can affect the different variables and how they can affect cardiac output. So, for example, if you exercise, you're going to increase cardiac output because you're going to increase sympathetic activity. Your muscle's going to contract more forcefully, right? The blood is going to return to the heart more readily, and so you're going to get a bigger preload, right? If you have epinephrine or norepinephrine in your body, or thyroxine, or excess calcium, so you could have too much calcium, this is going to actually increase the contractility of your heart, which is going to end up increasing your stroke volume, which is going to increase your cardiac output. And then sympathetic, if you have exercise or anxiety, your sympathetic activity is going to be higher than your parasympathetic, and that's going to increase your heart rate. So this just kind of shows how the different variables affect the cardiac output. Now, sometimes people can have some heart disease that affects their cardiac output. And so we can have what is called congestive heart failure. And what this means is that there is not enough blood in this particular instance being pumped out to the body. So it tends to kind of accumulate in the heart, and it can also cause congest in the lungs. So you can get too much blood, it's kind of staying near the lungs. But one thing that this can affect is the ability. So one factor is that you can have a decreased ability of the left ventricle to pump blood out to the body. So the left ventricle is really important, and sometimes the heart can actually get really flabby, and it can get kind of thin-walled, and then it just isn't able to contract. And so what they do for these people is they give them a ventricular assist, and specifically a heart pump, which is called a left LVA. There's an abbreviation for it. This is called the left ventricular assist pump. An LVA. And so people have these, a surgery where they actually go in and they actually put the pump inside of their chest cavity, and then they have to wear a battery pack on the outside of their body that provides energy for the contraction of this pump. And so if we look at a picture of that, right? And so here you can see that your pump is taking blood from the left ventricle, bypassing it, and then just bypassing the heart and taking it up to the aorta and then out through the body. And then this would be their battery pack. Okay. So the problem with this is that sometimes it doesn't tend to last very long. And so when people have heart failure like this, oftentimes they get put on a list where they are going to have a heart transplant, right? So they can just temporarily have this, right? This isn't very long lasting. And then the solution is to have a heart transplant. So the last thing we're going to do today is we're just going to watch a little video that shows a heart transplant and the process of a person who has this particular disease. This particular problem.
Montefiore Medical Center. With just 7 hours left before he drops off the priority list for a transplant, Bob Cunningham has finally gotten the call. A donor has been found, and this time the prospects are strong.
The donor team just left.
Okay.
Yeah.
Ready? Follow you.
This is it. Ready as we'll ever be. And we're ready.
With time of the essence, two of Montefiore's surgeons set out to bring back Bob's new heart. The donor, a 38-year-old victim of a car crash in North Carolina.
We are referred to as the harvest team, which is sort of a euphemism for the team that's going out to get the organs.
The team must fly to North Carolina, remove the donor heart, and return to New York, a distance of more than 1,000 miles.
That's the airport.
I hate to break this party up, but we really gotta get going up to the OR.
Fine.
Very much. You're gonna be good.
I'll be back in a while. Everything's gonna be fine.
Within about 5 or 10 minutes, they're gonna start anesthetizing him, putting lines in and everything. We want to be ready to cut skin by 7:30.
Not a perfect landing.
Everything depends on whether the donor heart is healthy. The Harvest team in North Carolina examines the heart before signaling doctors in New York to begin surgery. The two surgical teams must coordinate their work precisely.
So we just got a phone call from the Harvest team. They've looked at the donor heart, and the heart looks great. So we're going to head and proceed. The first thing is we're going to go back through his old incision, just open the same incision he's had, and then we have to deal with scar tissue. And it's very unpredictable whether that's going to be easy or hard. Remember, he's had 2 prior operations. It could be quite difficult to start digging to free up the heart. So we're going to get started. Incision.
In North Carolina, the critical moment has come. Bob Cunningham's new heart is removed and put on ice. Without blood to feed it oxygen and nutrients, the heart muscle cannot survive for long. The team has just 4 hours to get the heart back to New York and into Bob's chest.
We got very serious bleeding up on the chest. We need blood in the room. We got into some troublesome bleeding opening the chest. No, stop. We got a lot of air. Okay. Yeah, we're gonna have to circle rest.
Unfortunately for us, something bad happened right after the surgery started. You know, we cut skin and everything was fine, and we cut sternum, cut bone, and with all of the bleeding, it turned into, you know, a controlled emergency.
We're getting on the plane. It's probably an hour and 15-minute flight, and then about a 30-minute ground time. I think I go back outside like this. Anything you want to get.
As the surgeon tries to cut through the layers of scar tissue encasing Bob's heart, the bleeding grows out of control, making it impossible to see. With time ticking away, he takes drastic action. He orders all the blood in Bob's body removed and replaced with ice water, dropping his temperature to 64 degrees, slowing his metabolism and diminishing his need for oxygen. Bob is put into a state of suspended animation.
He's got no vital signs. I mean, if you look up at the monitor, he's got no EKG rhythm, no arterial, no blood pressure. So for the last 30 minutes, he's been pretty much clinically dead. We've drained all the fluid from the field, and he can actually work now to get through the scar tissue to visualize everything that they need to visualize.
You guys mind calling Mitchell? It'd be good to have an extra pair of hands. Wow, we stuck here, huh? Unbelievable. Where's this heart? Can you tell where the heart is?
Doctors have passed the point of no return. The surgery has damaged Bob's heart beyond repair. But they still have to cut through more layers of scar tissue before the new heart arrives from North Carolina.
We just landed. We'll be there in about half an hour. Bye. Some semblance of a heart here. Okay, let's see if we can go over here. Now let's get the left atrium cut, and then I'll be over. All right, here we go. I think you're gonna be good now.
With Bob still in a state of suspended animation, the doctors slowly return his blood to his body and raise his temperature back to normal. And now, Bob's 63-year-old heart, diseased, damaged, and still attached to the heart pump that has kept it beating for the last 2 months, is finally removed. Just as the donor heart arrives from North Carolina. Over the next hour, doctors will sew Bob's new heart into place. They must connect 4 vessels and let Bob's own blood flow into the transplant. Success will be measured by a single muscle contraction, the first beat of Bob's new heart.
Here we go. Here comes the clamp off. 0.5. Okay, clamp is off. Paddle switch. Go. Again. Okay, good. We have initial beat. I've done over 150 heart transplants. It's one of the toughest ones, for sure. I think he's going to do well. The only issue we're going to watch very closely is how does he wake up from the operation. Despite all the difficulties and challenges, I think we'll be okay.
So you saw when they removed the heart, the pump attached, right? That big metal thing was inside his body, right? Doing the work of the left ventricle. Okay. Any questions about that?
So do you know like what happens like when they remove the pump, like all that space that the pump took? Does that cause any problems or anything, or is that just?
I don't think so. I think that your organs just kind of move out of the way, and then they would just kind of like when you're pregnant, you have a baby, right? So your organs just kind of go back home to position. Okay. So remember that we have a quiz on Wednesday.